what I was speaking about was the role of the IAP in compressing and exiting nerve root. In short, the poorer cousin that is normally ignored. Because we stress upon the disc, we stress upon the flavum, we stress upon an upriding SAP, but we never think about the enlargement of the IAP. And today I'm going to talk about that one rare thing that is normally missed. So if you see this classification by an Italian couple that has been come up, it's a modified Kim's classification in the C23 segment. What you can see over here, sorry, I don't have a pointer. Can I have a pointer, guys? What you can see here is that there is a posterior bulge out of the IAP that is compressing on the nerve root. Now this is the reason why if you were to decompress this foramen from your normal internal approach and you miss out on this growth of bone, your nerve root is never going to be free. You have done the discectomy, you have done the flavectomy, but your patient is not improving. He's going to come back to you and you're going to wonder why this is happening. Now, why does this happen? Is because whenever there is, the story is whether the chicken came first or the egg came first. But if there is facetal arthropathy, there is rocking of the facet. And if there is going to be rocking of the facet, there is going to be an enthesiopathic change in the IAP. It's like a calcaneal spur in orthopedics. So this rocking movement causes a thickening of the IAP. Now, how do you visualize this? Normally what you would have to do is you have to take a coronasagittal angulation of the foramen, which is 14 degrees, and you have to have sequential cuts coming in. But that is what most centers don't do. So then what do you do? How do you analyze, okay, my patient could be having this? So simple thing is take a plain AP X-ray. If you see there's a thickening of the IAP in the AP, obviously there has to be somewhere thickening else in the sagittal plane also. So we will come to the logistics of the CT scan. Supposing I were to see a CT scan, then there are CT scan, there are 4 cuts or rather 3 cuts in which I pick up this thickening. I will show that to you in the images later. But now coming to the clinical approach of this issue, supposing I have the exiting and traversing root involved in a collapse segment with the IAP also coming, SAP also invaginating upwards, then I know that I have to free the traversing root. So then I will take an internal approach to even relieve the IAP pressure. Not only the SAP, I'll target the IAP also, but from within. Why? Because the traversing root is involved. But if only the exiting root is involved, then I'll do a para-UB approach or a Wilsey's approach. And sometimes when I feel that both roots are involved, again I am coming back to the internal approach. But now there is one more approach which I'm not going to show you now because I'm working on it, and that is what I call as a hop-on, hop-off approach, in which I work from inside and outside the foramen until I merge the 2 approaches. So I see the root at its origin completely. Now what do you see in this CT scan? You see a thickening over here. You see the subchondral thickening of the IAP. Compare it everywhere else. This is a thickened IAP. See this subpedicular cut where the transverse process is just generating. Transverse process here, that is the IAP pedicular junction up there, and you see that this is thickened. Here it is normal. This means that this root has to travel this little extra distance, and that is kinking this root. See the subpedicular cut. The subpedicular cut here shows you a thickened IAP on this side. So if you see your CT scans carefully, especially in patients who are above the age of 40, 45, who have these kind of symptoms, you can really pick up the contribution of the IAP to a foraminal stenosis. Let us play this video. It's a redo spine surgery. Patient has come to me with a traversing root symptom and an exiting root symptom. And I'm wondering, okay, Malcolm, this was done nicely. What is wrong with it? So I remove a little bone. I open up the fibrotic area, which opens up very nicely, and you can see the fibrosis on the root. There's a huge leash of vessels on the root. So now, okay, fine, traversing root symptom solved. I've cleaned the root, I'm burning the root, I'm coagulating the vessels that have grown over there. I'm going to put in some steroids, put it on Pirfinab, anti-fibrotic protocol, TNF beta blockers, all that is fine. But now look at this. I am now switched onto the opposite side of the patient. My scope is on the same side. And I'm looking into my own ipsilateral foramen. I'm looking at the chat standing on the opposite side, and I realize that the IAP is coming down and is pressing down on that nerve root. Now this is the advantage of UB. I can put in a burr in a horizontal angle under my own ipsilateral IAP, burr out that IAP over there, and eventually you will see a nicely exposed exiting nerve root. So I have solved the traversing nerve root issue, I have solved the exiting nerve root issue, and you can see the old fibrotic scarred disc over here. And this is the root which I have not even opened up the fat. But I have completely freed that root. So the pressure that was contributed by the IAP was causing the symptoms of the exiting root. There's nothing else there. What was there was on the traversing root. But the patient's exiting root symptoms were solved by this. See this image here. This is a very funny image. This is facetal dysmorphism. The change in the angle of the facets by more than 8 degrees. But you see the IAP carefully. The IAP is thickened and it has a hook. It has a bloody hook on the SAP. See the thickening of the IAP there. So I say, okay, let's go in. Let's have a look at this. And this is this patient's same MRI. Look at the thing very carefully. You are not able to pick up many things in the MRI. Let us play the video of that patient. No, wait one, sorry. Yeah. Let us play the video of this patient. And you can see this exiting foramen discal piece here. Now I'm gone in. I've removed the discal piece and I've exposed the root. Do you think this is enough? Is this enough? No. See this hook that I showed you in the CT scan. I'm osteotomizing that hook of the SAP so that my instruments can medialize and I can go in and trace my root upwards. I need to go closer because otherwise that hook is pushing me out. It's not allowing me to angle inside. So I go in, after I've done all that, I've removed that fragment the way Dr. Sharvari showed you that thing in my video. It's fine. But that was not the end of the thing. The root was white. The root was not free because we have an inner neck obstruction. We have an inner thickening of the IAP, and unless I trace this root, I am not going to be able to free the root completely. So now I start reburring on the thickened IAP, transverse process corner, and I'm keeping on going deeper and deeper until I reintroduce the kerosene, and I keep freeing the root further and further until the vascularity returns in the root and the fat starts pulsating in the axilla. You can see how this deeper part of this IAP is crushing down despite this bite. You see over here, this piece of bone is still crushing this root. So I have to trace this root, go parallel to the pedicle literally to release this pressure of the undersurface of the IAP. Did some part of the SAP too and freed the freed the traversing root too. But the whole issue is that you need to trace the root properly. This is one more video where you can see that there is a lot of fibrosis over here. This is a redo spine surgery. The facet is fused. The IAP, SAP tip and the IAP both are contributing. I'll just take a 30 seconds more, please. Bear with me. Unfortunately, it's a different laptop, so I can't time myself. And I'm breaking that piece. I'm finding out the fibrous root. And now I'm climbing up onto the root. I have to go onto the root. I have to go to the origin from where it was getting trapped. And you can see that as we burr on the root, you can see this edge of bone that is badly trapping this root here. So first of all, there is fibrosis on the root. You can see the fat below. There's a whole venous plexus here, which is tethered to the root. I have to cut open that to free the banding of this root. Sometimes these tightened veins, they band the root. You need to cut that also to open up this root completely. So now you can see the vein over there, that is the inferior communicating vein. I don't need to remove that. I'm climbing up on my root. I'm going cranial to my root. And going cranial to my root, I'm freeing this root from the pressure that the IAP is causing on the root. The SAP was already cut, fused. It's a redo spine surgery. But you see the contribution of the IAP. Unless you go up, unless you go to the origin or the source, अपन बोलते हैं ना गंगोत्री जमुनोत्री जाना to see the origin of the Ganga. So that's what I'm doing there. If you don't do that and if you don't free this contribution of the IAP, your foraminal stenosis is never ever going to be resolved. That is the take home message for you guys. I won't play this third video. This is extending my talk too much. Thank you so much for your kind time.